Hey, good morning, everybody. Welcome to Bold. Don't forget
We're in different seats.
That's right. We switched things up. We're going to switch a lot of things up. You're going to find out. This is the new Bold. We had some time over the Thanksgiving break to...
Bold, new bold.
Yes, we're bolder, we're badder.
Everybody's on Facebook
Yes.
right now. Share it.
Yes. Share, comment, like. We want to have your comments. I'll talk more about it, but we are going to have more of a debate scenario. And so we want to engage you guys more. So we'll get into that later. But first of all, today is December 2nd. And earlier this week, we had birthdays galore, which was exciting.
Yeah.
Including Bold.
One was exciting, one was less than exciting.
They're all exciting.
Yeah.
Winston Churchill,
Mark
always
Twain's
exciting.
birthday was on Wednesday. Winston Churchill's birthday was on Wednesday. Mine was on Wednesday.
Yes.
And Bold's was on
Bold.
Wednesday.
And cheers to Bold. Our birthday.
Oh, sorry, yeah, there you go. 1 year anniversary of Bold.
1 year. And if you want to celebrate with us, we've got Bold t-shirts, we've got all kinds of Bold swag. But it was also Clay's birthday.
No,
and
it was.
he
I
loves
skipped mine.
birthdays.
I did a deal
Clay
with the
loves
devil, and I
birthdays.
don't have them anymore. See, no birthdays this year. But yes, I did have a birthday on Wednesday, but the one that we are celebrating the most is Bold's 1 year anniversary on Wednesday. So you can definitely check out bold.global to see all the exciting things that have happened at Bold over the last year. And we've been here not a year, but sometimes it feels like it.
Well, and I know, Clay, you had a birthday,
Yep.
and you got to take in a Broadway show, but you also had a birthday wish.
Oh, I did, yeah. A friend of
yeah.
mine, one of the guy who actually has been my security guy, from the moment I walked off the stage on Idol, they said, hey, Clay, this is Jerome. He's going to be with you. And he stood next to me for 14 years now as security. And I can't think of many people in my life who have been as close to me. I'd say he's been a father figure to me for all these years, maybe more so than people who could have filled that role, but he was in a horrible accident last week before Thanksgiving, and really life-changing accident in Atlanta. And so there's a fundraiser online, and I think you can find it on bold.global for people to kind of help. You get a little bit more of the information about what happened with Jerome and how you can help out if you're so inclined to do that. That was my birthday wish this year, and Jerome's birthday is actually 2 days after Christmas, so we're going to try to set this goal to be completed by his birthday.
Yes. No, I mean, whatever you can do to help Jerome and his family at this very, very difficult time.
And thank you for bringing that up. I appreciate it.
Of course, of course. Yeah, no, he's part of the Bold family.
Yeah. So, but Bold's doing some new stuff.
Yeah, we're mixing it up. We want to try tackling some of the big issues of the day through debates. And now that we have a new administration coming up, things have already been heated, but they were, a lot of politics, and now we're getting more into policy because now it's time to govern. There's new framework, new people in office, and so there's a lot to talk about. And
so for this episode, we're going to tackle one topic for most of the episode, Medicare, and the changes that may or may not come to Medicare, how people feel about them. And so we're going to start with what I like to call our educational segment. We brought our chief medical correspondent, Dr. Campbell, is here with us today.
Bold swag.
That's right.
He's got his T-shirt on proudly to talk about Medicare, to talk about changes to Medicare that have been proposed, some of the ones and how people feel about them, and not so much opinions, but really kind of give us some facts on what changing Medicare might look like and what it might do. So thank you very much for being here.
Thanks for having me.
We also have Jeremy Binks from Salon. He's the cover editor for Salon.com.
Thanks for having me.
And we're excited about him being here because he is going to take on the illustrious Carrie Sheffield in our second segment. You have that to look forward to. Kevin and Jeremy, thank you both very much for being here.
Much.
So Kevin, talk to us a little bit about kind of what we're talking about today, about Medicare, what it has done, enrollment numbers, any of that stuff, what it's done over the 40-some years that it's been around, and maybe some of the things that are being proposed as changes for it.
Sure. As you know, Medicare was created in the 60s to take care of those who were older who may not be able to get coverage because at that time insurance companies could say, if you have a pre-existing condition, we're not going to cover you. And so a lot of people were left out. And so it was created there as kind of a safety net. And as time evolved, Medicare enrollments grew and grew and grew, and the cost of taking care of those patients grew and grew and grew. And really, the Medicare system has not really kept up with the times. For the practicing side, there's lots of rules and regulations for physicians, often very difficult to file when you need to file claims to get reimbursed, and then the reimbursement rates haven't really kept up with the times. So what's happened is a lot of physicians, even though we love caring for people, and that's why we went to med school, aren't able to take Medicare patients because you can't keep the lights on and pay your staff with really, really crummy reimbursement rates.
So now explain to me, and explain to all of us, doctors are allowed to determine whether or not they're going to take Medicare, but the Medicare reimbursement doesn't always necessarily cover the cost that you would normally charge a regular patient or another insurance company, yes or no?
That's exactly right. You know, Medicare reimburses at rates that are much lower than traditional insurance in a lot of cases. And, you know, the problem is that, you know, Congress is forever doing these last minute budget deals to get, I don't know the right term, I'm sure you do, to, you know, patch things for 3 months or for 90 days or for 6 months so that we can actually get reimbursed. With Medicare, if I'm taking Medicare patients and filing claims, if they decide they're not going to pay for 90 days, they don't have to pay. And so you're stuck with this gap if you're a private practitioner where you can't collect to pay your bills.
How's that different from a private insurance company and your relationship with them and how they pay you back?
So private insurers, you file and you get paid pretty quickly for the most part. It doesn't always work that way, and private insurers have their own issues right now. And that's one of the things I wanted to talk about is increasing competition, because private insurance companies now, they can argue about whether a patient needs a pacemaker or not, and they're not trained like I am. They have no idea. Yet they want to argue from a script and try to deny care. So private insurers have a lot of trouble too.
Does Medicare do the same thing? Do they make decisions as well?
So Medicare has guidelines and things that you have to have in that office note that will allow it to be reimbursed. And so you know what those words are, the things that you must document in your electronic record they have to be obviously true, but there's things you have to document. And if you document those things, most times that does get approved.
Any questions, Carrie and Jeremy? You guys jump in here. You're going to need some information in a few minutes, aren't you?
Okay, sure. I'll start. Keeping up with the times. Let's talk about what Medicare is and how it's evolved. We have 4 parts to Medicare: Part A, Part B, Part C, Part D. You know, this is probably going to get into the weeds here, but can you get into a little bit of what Part A does, what Part B does, and so on and so forth?
So it's fairly complicated, but basically Part A is going to pay for hospitals and hospice and that type of care. Part B pays physicians and equipment and things like that. Part C pays for some other things, and then Part D is the drugs and the drug plans. And unfortunately, it's very arduous, the system to connect all these different things, and it's very hard on the patient to figure out what in the world they have to do. And a lot of patients are buying supplemental insurance to cover gaps in care.
Right, and with supplemental insurance, we run into the problem of sometimes companies on the private market are offering this insurance that is covers less than Medicare, or it's misinterpreted, or it's mispromised, mispromoted. You know, how has the government been taking that on?
So I don't think we've done a very good job of that, and that's what I think lacks about the Affordable Care Act and any type of healthcare reform we've seen in the last 2 decades is the fact that insurance companies are really left to run wild, and they take advantage of elderly people who oftentimes as we age, we don't think as clearly. Dementia is very common in Medicare type patients. And I think, unfortunately, these people are really preyed upon by insurers. And I think whatever happens in the future, insurance reform has to be a big part of it, because these are companies that are making tons of money, lining their pockets, and all they want to do is say no.
So then, because I want to make sure we get every side of this here, Medicare Advantage. Talk about Medicare Advantage and why, if that's the case, the government has obviously at some point determined that there are reasons that some elderly people may want to be with private insurance, and that's what Medicare Advantage is. Explain to me and on all of us what Medicare Advantage is.
So what that is, that allows you more choice, and you're going to pay more for that, but it allows you more choice. If you're just in plain Medicare, you don't often have a lot of choice, and if you're in an Advantage program, you're able to spend more money. The problem I have with that is it creates 2 classes. You have more affluent elderly folks that can afford to pay these extras, and then you have other people who just have no choice. And we have to figure out a way to provide high quality, affordable health care for everyone, no matter what your job is or what your financial status is.
What percentage are in Medicare Advantage versus regular Medicare?
You know, do you know, Jeremy? Because I don't know those numbers.
About a
No, I
third.
don't-
About a third of
Third
seniors
is
are in
Yeah, I'm
are in
sorry.
Medicare
Yeah.
Advantage.
Yeah.
I'm a little bit over a third, about 34%.
Okay.
Yeah, and they're more satisfied, wouldn't you say? The seniors who are enrolled in Medicare Advantage are more satisfied.
Absolutely. Anytime we as patients or as citizens have choice and we can determine what we're going to do with our bodies, with our health care, that's better, right? And when you don't have choice and you feel like you're lost, then I think you're more dissatisfied. And also, when you don't have choice, you're at the mercy of the system. And I have so many patients come in my office and they say, I'm in the donut hole, which means they have these expensive medications that it's a gap in coverage that they can't afford. And so then I have to go and try to find samples for them or some other way to prescribe medicines they really need.
So out-of-pocket costs for someone who's on Medicare, on a not the Medicare Advantage program. Give me an average on copays, percentages, et cetera.
You know, in our office, a copay could be anywhere from $20 to $50, and that's a lot of money in rural North Carolina. And I, unfortunately, as a specialist,
That's on Medicare.
yeah, and as a specialist, sometimes I'm sitting there doing primary care because my patients come in to see me for a heart problem, and they can't afford to see their primary care doctor that same month. So I'll write them for their diabetes medicine. I'll take care of their blood pressure and other things.
How does that compare to someone who might be on private insurance? Their copays tend to be, if they have a average to good plan, tend to be lower. Higher?
They'll be lower, but if they have one of the plans that has a higher deductible, they're going to have a much, much higher copay. And then there's networking to where if I want to see a doctor out in network, it may cost me $150 to see that doctor as a copay as opposed to $20, $30, $40 in network.
Now, I want to circle back to the question of satisfaction. Satisfaction is a very weird, nebulous term, especially when it's being brought up. Yeah, you can be satisfied with Medicare Advantage or anything. I recently had to look at my healthcare options, and I got a PPO and EPO, and I'm trying to make heads and tails of it because it's filled with legalese and it's filled with you're going to take 30% off of here, but there's going to be a $20 copay. These things are designed really to be incredibly difficult, incredibly complex to maneuver. So when someone says, "Oh, I'm satisfied with it," and this comes. I'm not sure if you have these you have these conversations with your patients, but do they know that maybe this option is not the best option because they're going to be paying more for this than they're not? I mean, it seems like there's some sort of information that's missing here.
And I agree with you. I think that's the issue with the insurance companies. I think that they on purpose make it so complex you don't really know what you're buying. My wife recently had to do re-enrollment, and I'm on her insurance plan. And when we did that, we're physicians and we couldn't figure out which plan was best. So, it's very, very difficult to understand that. And I think we need a more straightforward kind of even kill across the board. If you want to pay more for a lower deductible, great. But
Well, and so that's my question is, under Obamacare, it seems like it's very cookie cutter and it's also lacking in transparency. Do you think that part of that lack of transparency stems from the fact that there is no competition?
I think that free market competition, particularly in healthcare, makes a huge difference. In North Carolina, we have all these mega hospital systems now. And, we like to think we're providing high quality care and service, but I think when a consumer doesn't have any choice, quality of care and services goes down from the way the front desk staff treats you to, how quickly you get to see the doctor and all those things. And I think the same is true with insurance. I need insurers to compete for my business as a physician and compete for my patient. I don't want to spend 2/3 of my day arguing with some idiot on the phone who doesn't know anything about the procedure I need to do to save a life when I could be in the operating room saving a life.
So before we move on, because I want to keep on this, but we had a poll on we put a poll on Facebook earlier.
And Twitter.
This week, and Twitter earlier this week, where we asked people a question, very simple question: privatizing Medicare. Whether people agreed with it completely, partially privatize it, not at all. We got a pretty obvious split right now. But what we want to try to do here with our modified format is to see if people's minds might change. So without any opinions whatsoever, I just want you to please, if you don't mind, for us, Dr. Campbell, tell us what is being proposed potentially when it comes to privatizing Medicare, what it would look like. and what Speaker Ryan has proposed in the past and what may come up in the next Congress?
It's a great question, and my understanding of what's being talked about is a voucher-like system where the U.S. government, if you're a Medicare beneficiary, gives you a choice. You can be on plain old regular Medicare, or you can get a certain amount of money that they determine based on where you live and cost of living that you use to purchase private insurance. And if the private insurance is more money, you're going to pay that extra. And that gives people choice.
Who determines the cost of living would be determined based on state, based on area within the state, and who makes that decision?
So at this point, it would obviously, I think, Health and Human Services and the departments under HHS. So it'd be.
Would they go to block grants to the state? Have they discussed that? Do they?
I haven't seen that kind of detail, except when you talk about Medicaid reform, they're really talking about block grants for states.
But for
and I think that Medicare, it's more, I think, they're going to look at what does it cost to live in New York City and to see doctors is going to be very different than what it costs in Raleigh, North Carolina.
Now, would that get rid of Medicare Advantage in general? It'd make everything Medicare Advantage, essentially?
I think everything would be Medicare Advantage-like, or you'd be in regular old Medicare. Now, the issue with that are twofold. I think that the more affluent people who are beneficiaries get choice. Those that don't have those means may not have that choice. What I worry is the people who are more affluent, because they have access to better preventive care.
That whole part about not being biased, where did you not understand?
I'm going to say both sides of this. No, I'm going to say both sides.
I'm trying to help you out here, Carrie.
No, I'm saying both sides.
Keep singing.
My issue with that is that if you have the more affluent people, they're typically less ill. They don't have as many chronic diseases because they have access to preventive care. The folks in regular Medicare are going to be sicker, they're going to be older, multiple medical problems, and cost more money. So there's an argument that may be really tough to pay for, and these patients may not get the care they deserve. But there's also an argument that, choice is good, and we want choice. But we've got to figure out the right way to do this.
What you're saying, sick old people cost a lot of money. That seems like the situation that we had in the 1950s that spurred the Medicare Act,
Right.
the Medicare Adjustment Social Security. So there are reasons why insurance companies don't like getting on Medicare.
Risk pool.
Exactly.
Yeah.
Now we're getting to risk pools that we talked before, which is way too in the weeds. But old people are going to cost a lot of money. Mm-hmm. They're going to take a lot of time, a lot of effort to fix, and no one wants to be a part of it. Is this true?
This is what we need to do, and this is what's wrong with medicine. We focus on treatment of disease. We should be in a healthcare system that focuses on prevention of disease. Spend money on the front end, making sure you don't smoke, making sure you don't have diabetes, making sure your blood pressure is controlled, that you exercise, that you eat right, so that I put myself out of business and we don't need to take you to the operating room for a bypass surgery, which is going to cost $150,000. Spend $25,000 over the first decade when you're at risk. Modify lifestyle. 1 in 3 children are obese. 1 in 3 kids are going to have type 2 diabetes, hypertension, heart disease. 1 in 3. We've got to do something about it.
Yeah, no, we're a spoiled, overweight country.
Yes.
Like 2/3 of adults are overweight, in fact. So it's in those overweight, middle-aged people become overweight elderly people, and that's a much bigger problem, I think, than like you said, just treating the aftermath versus preventing it. But what about private insurers in terms of, when people retire, what percentage are able to maintain sort of their, let's say you worked at wherever. I worked on Wall Street at Moody's. Like, let's say I retired at Moody's at 65. How can we incentivize companies to keep people on their plans even if after they're retired instead of kicking them off?
I think we've got to, and I hate to say this, we're going to have more insurance company regulation. We have to hold insurance companies accountable for caring for patients. That's what they're there for. Instead of lining their pockets, just like the pharmaceutical companies are doing right now, at our patients' expense. I don't have all the answers here. I just know that what we have is broken, it doesn't work, and I'm hoping that you two guys can work this out today in a debate, and maybe Representative Ryan and President-elect Trump and some other people will actually listen to you guys and make a difference in our patients.
That's what we're going to try to do right now. Dr. Kevin Campbell, thank you very much
Thanks
for
for
being
having
with
me.
us.